Imagine a neurologist evaluating a patient who walks into the clinic with slowly progressive stiffness of both legs, exaggerated reflexes, dysarthria, and a spastic gait. The examination reveals a pure upper motor neuron syndrome. The neurologist begins to suspect primary lateral sclerosis, PLS, but immediately reminds himself that PLS is not diagnosed by proving its presence, but by excluding every possible mimic. The first visitor to the differential diagnosis room is ALS, the closest and most dangerous mimic. The neurologist carefully looks for fasciculations, muscle wasting, and lower motor neuron signs. An EMG is performed to search for denervation. If lower motor neuron involvement is found, the patient leaves the PLS pathway and enters the ALS category. Next comes hereditary spastic paraplegia, HSP, usually arriving with a younger patient and often accompanied by a family history. The neurologist asks about affected relatives and considers genetic testing. Then arrives cervical spondylotic myelopathy carrying neck pain, sensory symptoms, radicular pain, and bladder disturbances. MRI of the cervical spine is ordered to ensure that spinal cord compression is not masquerading as PLS. Soon after, multiple sclerosis and primary progressive multiple sclerosis appear. They bring optic neuritis, sensory symptoms, cerebellar signs, and demyelinating lesions on MRI. Cerebrospinal fluid examination may reveal oligoclonal bands pointing away from PLS. The neurologist then remembers the tropical traveler, HTLV1 associated myelopathy, who usually presents with progressive spastic paraparesis and bladder dysfunction. Appropriate serological tests are sent. Structural lesions of the spinal cord then enter the scene. Tumors, syringomyelia, arachnoid cysts, and compressive myelopathies can all imitate PLS. MRI of the entire neuraxis becomes essential. The metabolic culprits follow. Vitamin B12 deficiency and copper deficiency myelopathy often leave clues in the form of sensory ataxia and posterior column involvement. Blood investigations expose these masqueraders. Adrenomyeloneuropathy arrives next, bringing adrenal insufficiency and elevated very long-chain fatty acids. The neurologist keeps this rare diagnosis in mind, especially in younger male patients. Paraneoplastic myelopathy and neurosarcoidosis also knock at the door, often accompanied by systemic manifestations that suggest an underlying malignancy or inflammatory disorder. The vascular and infectious causes are not forgotten. Spinal dural arteriovenous fistula, HIV-associated vacuolar myelopathy, and neurosyphilis can all produce progressive spastic paraparesis and therefore deserve consideration. Finally, the rare genetic disorders enter quietly. Adult-onset leukodystrophies, mitochondrial diseases, and adult-onset Krabbe disease. After every mimic has been questioned and excluded using MRI, brain and spine, EMG and nerve conduction studies, metabolic screening, infectious testing, autoimmune evaluation, and genetic studies, the neurologist returns to the patient. Years have now passed. The patient still has only upper motor neuron signs. There are no fasciculations, no muscle wasting, and no EMG evidence of denervation. Only then does the neurologist confidently conclude this is primary lateral sclerosis, a diagnosis earned not by finding something, but by excluding everything else. This story follows the same sequence many neurologists use clinically and can serve as a memory aid during examinations and viva discussions.